This second lecture in our ECG, basic ECG series will focus on the ST segment in coronary ischemia. At the end of this lecture, you will be able to identify common ST segment changes induced by coronary ischemia. Just reminding us of the systemic approach that we spoke about earlier, and for today's lecture we're going to talk about the ST segment. Bear in mind, even in this situation, we must look at our patient first, find out if they have a pulse and whether we need to start cardiac arrest management, figure out if they're stable, and focus on stabilizing the patient before we pour over the ECG, and if there are cardiovascular system abnormalities. Also, bear in mind that particularly in ST elevation, as we will see in the consequent lecture, we need to know what the history is, because ST segment elevation and changes can occur because of things other than ischemia, such as electrolyte imbalance or drug toxicity, which we'll talk about in the third lecture of the series. So, ST segment changes in transmural infarcts are usually ST segment elevation. There are some things called STEMI equivalents, and these are usually associated with transmural infarcts that are not in areas primarily served by any of our standardized leads, or due to critical ischemia, which may not yet be transmural, but if left is most likely to lead to ischemia, and therefore treating them as a STEMI makes sense, even though they don't quite fulfill the criteria. In less severe ischemia, we may get subendocardial infarct because of the supply of the heart is from the epicardium into the endocardium. Less severe ischemia tends to affect the endocardium first. In this kind of instance, such as transient ischemia of vagina or subendocardial infarct, what we get is ST segment depression or symmetrical T-wave inversion, which we will mention at the end of this talk. How do we localize the area of the heart that is infarcted? Well, this table reminds us which leads represent which areas of infarction. You may want to stop the talk at this stage and just remind yourselves of which leads represent which area. Also, which area is supplied by which blood vessel, because those things do come in your exam and are important in terms of interpreting and understanding 12-lead ECGs. The other thing you have to remember is that while the ECG lead facing the infarcted area will show ST segment elevation, any opposite leads will show ST segment depression, and these are called reciprocal changes. Again, this table outlines for any given infarct which leads show primary changes and which leads will show reciprocal changes. It's again just going back to the thing about ST elevation, STEMI equivalence. If you look at a posterior MI, there are no leads that show ST elevation changes because there are no leads pointing to the posterior aspect of the heart. All your clues come from reciprocal changes. Right, let's look at some ECGs. So these are all patients who have come in with coronary artery type syndromes, shortness of breath, chest pain, diaphoresis, syncope. Look at this guy. Comes in. This is his initial ECG. Well, you see primary ST elevation in V1 and V2 certainly, and then some suggestion in V3, possibly V4. There are reciprocal changes in the lateral leads and the inferior leads. This is in fact a septal infarct which is extending somewhat to the anterior surface of the heart. So an anteroseptal STEMI. What about this one? For each of these, I just want you to pause the video, have a look at the ECG, and then make a determination. And then you can continue the video and hear what I have to say. Well, in this one, you can clearly see ST elevation in lead 2, lead 3, and AVF. Remember, this is AVR, L, and F. So let's think about that. Lead 2, 3, and AVF. Which leads do these represent? Okay, some of you would have figured out that these represent the inferior leads. And then if we look at the lateral leads, 1 and AVL, we see ST segment depression with T wave inversion. These are reciprocal leads. Unfortunately, this ECG has been cut off and doesn't show V4, 5, and 6. This is V1, V2, and V3 here. So we have ST elevation in the inferior leads and ST depression and T wave inversion in the reciprocal leads. This is an inferior ST elevation MI. Here's another one. Have a go at figuring out what you see in here. Pause the tape, work it out, start it back. Okay, another fairly clear-cut example. Let's look at where these leads. Let's start with leads. Lateral leads, 1 and AVL in particular, show marked ST elevation. And then if we go to the lateral leads on the precordial side, they clearly show ST elevation as well, but this extends to V3, V4, and even up to V2. So this is anterior, but this is lateral. So this represents an anterolateral infarct. For each of these, I also want you to try to figure out which vessels are involved and at what level. Finally, this one. Stop the video and try to work out what's going on here. So probably the most striking thing on this one is that there's no obvious ST elevation, maybe a little suggestion in lead 3, but nothing much. However, there's something really odd going on in our anterior leads. Look at V2 and V3 in particular. Tall R waves, ST depression, T wave inversion, or biphasic T waves. This is very classic of a posterior MI. When you see this pattern, think posterior MI. What's your next step? Most sensible next step here would be to get your posterior leads done. B7, B8, and B9 behind the left heavy thorax. And those will show ST elevation if this is a true posterior MI. Here's just another example of a posterior MI. R waves, ST depression, V1, V2, and less so in V3. Some reciprocal changes actually in the lateral leads here. So the criteria for diagnosing a posterior MI is that you have ST depression in the anterior leads, upright T waves, and, sorry, it was shown here, prominent R waves in V1 to V3. Again, pause the video and tell me what you think this shows. So actually that showed left bundle branch block, and it's just to make the point that diagnosing acute coronary ischemia in patients with left bundle branch block can be very difficult. And these days we use something called a modified Scarbosa criteria. So in concordant leads, so if the QRS complex is positive, then the ST segment elevates by at least 1 millimeter. These are pioneer leads. Or if the QRS is negative, the ST segment depresses by at least 1 millimeter. Or in leads V1 to V3, you have concordant ST deviation of at least 1 millimeter. Remember that V1 to V3 are usually predominantly negative. Or in discordant leads, where the QRS is going in one direction, the T wave is going in the other direction, you have ST elevation that is at least 25% the total ST segment. So these criteria are fairly specific, but not very sensitive. However, they can help us diagnose a STEMI in the patient with left bundle branch block. The truth is, if you have a patient with left bundle branch block and STEMI, the best thing to look for is an old ECG to compare their old bundle branch block with their new bundle branch block. What about this ECG? Actually, it shows hyperacute T waves seen in V2, V3, and this is sometimes seen in very early changes of coronary ischemia, and of course in other things such as hyperkalemia. And finally, this one. This is the symmetrical T wave inversion we talked about that you can see in subendocardial infarction. So if you have any questions or comments, please post them on our WhatsApp page or bring them with you to Wednesday sessions. In summary, we have continued to use our structured approach to diagnose our ECGs. The next lecture will look at ST segment changes due to electrolytes and drugs.